a general continuum of stability and mobility within those articulations. If we look at the shape of the bones articulating with each other, we can determine exactly what type of motion will take place, and we can determine how many degrees of freedom we will see. Based off of how we use that articulation, we will refine and reinforce the shapes of the bones, and we'll talk a little bit about the changing shape of the femur and the changing shape of the humerus as we look at those bones in lab, and talk about how we have structural changing around the articulation in development and in childhood. But what we do get, regardless of how well we use the articulation, is a inverse relationship between how much mobility we have at an articulation and how stable that articulation is. Where the glenohumeral articulation, the articulation between the glenoid fossa of the scapula and the head of the humerus, is the most mobile that we have. And this allows us to have the greatest amount of motion, and we'll talk about those motions here in a second, in between the humerus and the scapula. Whereas the least mobile are the suture junctions that we see in between the bones of the cranium. Now, it's not immobile, meaning that there will still be motion that takes place. It's just that there's so little motion that's there that there is such great stability between the articulations there. So as we increase stability, we decrease the amount of motion that we see. And as we increase the amount of motion that we see, we decrease the stability. Now, that decreased stability that we see within the articulation is going to be an indication that we have to have some sort of secondary stabilizing unit around the articulation. And so what we see is with articulations where there's a large amount of mobility, we start developing what's referred to as the dynamic articulation. That is, we have an articulation that's going to integrate multiple components of the musculoskeletal system so that the joint is relatively stable, the articulation is relatively stable, but still has a large amount of mobility. Now, the amount of movement that we see at the articulation is going to be influenced not just by the shape of the bones that are articulating, but also the pattern of ligamentous structuring around the articulation, where the ligamentous structures that we see are going to be restrictive to the motion that's allowed at those articulations. In the handouts, there are a host of ligamentous structures within each of the articulations. And based off of how those ligaments arrange themselves around the articulation, we can look at those ligaments and determine how much motion can we get at the articulation and what direction will those ligaments allow motion to take place. We can also determine the relative risk for injury to those ligaments based off of what pattern of motion they are limiting. So those articulations that need additional support, we reference as being dynamic articulations. We'll talk about two such examples here of a dynamic articulation. The first one is at the glenohumeral articulation. And this is where we have capsular ligaments that meld and mesh with the tendons of the rotator cuff muscles. The way in which the head of the humerus sits into the glenoid fossa, the head of the humerus is much larger than the glenoid fossa and actually is unable to move around. Plus, we have to be able to glide it inferiorly in order to abduct the head of the humerus past about 30 degrees. That inferior motion can actually lead to subluxation, movement of the head of the humerus out of the articulating surfaces. And so what ends up happening is that the rotator cuff muscles, the tendons of the rotator cuff muscle, are able to change the tension of the capsule And that changing of the tension of the capsule allows it to change the joint stability as we accelerate rotationally through the central axis of the joint, and modifies the amount of torque that we see in the motion itself. Now, along with the rotator cuff muscle, we will also get a couple other tendons coming into play here, such as the tendon of the long head of the biceps brachii. And so what these tendons do is that they meld and mesh with the capsule itself, thereby allowing for a stable glenohumeral junction that still allows for the maximum amount of mobility, thereby allowing us to circumduct at the glenohumeral junction. The problem with this is that we have a whole bunch of tendons and ligaments and bursas seated into a very, very small space, where any type of protracted motion at the scapula leads to closing off via internal rotation moment the head of the humerus and the capsular space that's available, and leads to what is usually referred to as a rotator cuff or subacromial bursital issue. We usually associate these issues with people who play sports and throw a lot, like baseball players and softball players and sometimes football players. But we will see the same type of issue come about from people who spend a lot of time sitting in a protracted position, such as having to type on keyboards, or people who sit with poor ergonomic posture. The other dynamic articulation of importance is what's referred to as the plantar fascia and arch of the foot. The plantar fascia and arch of the foot is a combination of about 7 different ligamentous structures and some tendons. The principal ligamental structures are going to be the spring and longitudinal ligaments that come on the plantar surface of the tarsals heading to the metatarsals. And the long plantar and spring ligaments hold the arch of the foot in place during compression of foot load. Where combined with the plantar fascia, which is running from the hook of the calcaneus to the hooks of the distal edges of the tarsal bones, and metatarsal bones, what they're able to do is that they're able to keep the arch intact as long as the navicular bones stay in place. So the navicular bone is just going to be just anterior to the talus, just anterior superior to the calcaneus, just posterior to the cuneiforms. And it acts as the keystone to the arch of the foot. What's happening is that as we load the foot, as we come down on a foot strike, like when we walk or when we run, the arch of the foot will start to flatten out. And what's happening is that the plantar fascia, the spring, and the long ligaments, what they do is that they hold the arch in place and don't allow it to splail too far. And what it does is it starts to act as a leaf spring. It acts as a leaf spring. What it does is it stores energy into the foot. It stores energy into the foot that combines with the elastic potential energy of the calcaneal tendon, the Achilles tendon. And what it does is it provides additional kinetic energy from the foot to propel the body forward during walk and run. The faster you move, the more rigid you keep the foot. And the more rigid you keep the foot, the greater the return of energy that takes place as you push off. The problem with this setup is that we have a very fragile arch. And people who go from a shoe or footwear that is highly unsupportive to a shoe or footwear that is highly supportive and back to the shoe that is highly unsupportive and then back to the shoe that is highly supportive. And the people who go from having a broad toe box to a narrow toe box, what they do is they constantly change the tensional line points of these ligaments, and it can lead to excessive wear on the plantar fascia and excessive wear on the long and spring ligaments. When these ligaments and structures start having excessive wear on them, they will start to inflame, and that's how plantar fasciitis comes about. When we talk about the synovial joints at play here, we're talking about 6 classifications of articulations, in which we have ball and socket, in which we have a convex head fitting into a concave fossa. Examples of the ball and socket that we see are at the glenohumeral and the femoral acetabular. The hinge, in which we have a convex and concave surface that are non-spherical. The hinge joint that we see is at the ulnohumeral articulation. We have a saddle in which we have 2 concave structures sitting on top of each other. This concave structure allows for rocking to take place. We see this at polys, at the metacarpal carpal junction. The ellipsoid is where we have, also known as a condylar, is where we have a convex concave surface. However, the convex concave surface is not spherical. It's oval. A pivot is where we have a flat surface articulating with a convex surface or a concave surface. We have a true pivot at the atlo-axial articulation, and we have a pseudo pivot at the ulno-radial articulation. Gliding is where we have 2 flattened surfaces articulating with each other. Those 2 flattened surfaces will allow for motion in one plane at a time, or a pivotal rotation transversely across them. We see these at the acromioclavicular, the sternoclavicular, and at the tibiofemoral. Based off of the shape of the synovial joint, we can determine which articulations will have the greatest amount of motion that takes place when we start looking at where we will see the various types of movements.